Hello, good afternoon, everyone. I'm Monica Miranda. I work in the same team as Jaira Castro with Dr. Robert Gilman in the School of Public Health at Johns Hopkins. I'm going to talk about Chagas disease and the pregnancy and the specific case of Baltimore. A lot of what I'm going to say has already been said because we're all looking at the same problem. However, why Chagas disease in Baltimore specifically? Baltimore city's overall population diminished by 4.6% between 2000 and 2010. So this is a particular context because this is the reason the Latino population has grown so much in this particular city. In 2012, part of for economic growth and population, the mayor signed an executive order to protect immigrants from saying whether they were undocumented or not. And this led to Baltimore to be sort of a haven for immigrants. And the Latino population grew by 134%. Remember that Chagas is very latent. It doesn't matter if you have been 20 or 30 years in the country, you can still have it and not know it. So this is very important. One very important thing about Baltimore is that if you have read the news, you know that, for example, the Mexican population, the migration is actually reversing. The past couple of years have been Mexicans are going back to their countries, in part because they're aging and also because the reasons for migration were different as the current immigrants. And that's also very important. Immigrants from El Salvador and Guatemala and Honduras are migrating for different reasons. A lot of the reasons they're migrating is because of violence or drought, stuff like that. And in the particular case of Baltimore, what we see is that they are fleeing violence. And this is a reason they feel sort of threatened to go back to their countries. So they're seeing the United States sort of a place to come and stay, and they not necessarily want to go back to their countries. A lot of these immigrants are very young, and the fertility rate is really high. So 17% of births in Maryland are of the Latino population. And this is it's less than 6% of the population is Latino, and 17% of births are from Latinos. We know that this population is expected to grow. And in most states, US-born Hispanics outnumber foreign-born Hispanics, but the case of the District of Columbia and Maryland is a bit different, in which almost the majority or half are foreign-born still. This is one of the risk factors for Chagas. So here on the left, you have a map taken from the census of 2000, and you can see the percentage of Latino population living in each neighborhood. And then to the right, you have it for 2015, and you can see how the population is really growing in the city. So this is very important for us to know that Baltimore specifically might be a good place to look at something like Chagas disease, even if we don't have that many, like in numbers, we don't have that many immigrants. And why Chagas in pregnancy? Dr. Shiva has already mentioned that it's very important to look at primary health care and to get to Chagas disease before the consequences of cardiac or gastrointestinal consequences are manifested. So pregnancy is a good way to start. I agree that before pregnancy it would be ideal. However, we want to start with pregnant women for a few reasons. We know that undocumented immigrants might not have insurance, and when they get pregnant, a lot of these immigrants do get some sort of access to healthcare. So in the specific case of Baltimore, there's the Total Access Partnership that allows women to be seen at the Johns Hopkins Bayview Medical Center. So this is a good opportunity for us to reach them. And also, let's remember that vertical transmission is an important means of getting Chagas in the United States. Maybe 5 to 10% transmission rate. We have to look at this. One very important thing of knowing why our immigrant population is changing is also the lineages of Chagas. We know that different strains involve different types of diagnostic or different responses to treatment. So the United States is very good as a way of, we have a good opportunity to do research in the United States because we have immigrants from all over, so we have all the strains here, and it's a good opportunity to look at the disease. What we're doing in Baltimore, we haven't started data collection yet, but our aims are going to be estimate the seroprevalence of Chagas disease among the Latino pregnant women, to compare the same point of care in BIOS test to the ELISAs that Yahaira already mentioned in her study, and the TISA blood, and to compare pregnancies of women seropositive to T. cruzi to those women seronegative to T. cruzi, because as of now, one, we don't screen for Chagas disease in pregnant women, but we have not evaluated pregnancy with Chagas in the United States and how this affects pregnancy. This might, if we look at this, we might have a better idea if having Chagas would involve a high-risk pregnancy or not. There's a few studies that have been done in endemic countries, and some of them indicate that the vertical transmission, once you have all the healthcare services and you are providing adequate care, vertical transmission remains, but other factors might not exist. We need to look at that here in the US to see if there's something to be of concern, for example, low birth weight or low Apgar scores. Okay, so this on the top you can see the caravan. This is an outreach van that has services for the Latino population in Baltimore. It's part of the Johns Hopkins Baby Medical Center. They screen for pregnancy and they refer for prenatal care to all the women, eligible women that can be part of the TAP program. And they refer them for prenatal care to Johns Hopkins. And we're using this and Baby Medical Center as our both recruiting sites. We're also using the InBios rapid test to screen for women, to screen for Chagas disease, but we're confirming with the ELISAs as well. So we're first going to do a questionnaire and draw the sample for screening. And we're going to look at the pregnancies through sonography. It's 2D and 3D sonographies. We're going to look at different factors. We're also going to use the questionnaire to see how the pregnancies is going. And in the last prenatal visit before delivery, we're going to look at venous blood and urine to see if the parasitemia has anything to do with vertical transmission or not. And we're going to follow both the mother and the baby to see whether, one, to see the diagnostic of the child as well. This is very, as you can imagine, the sample size to get congenital cases in the United States is quite challenging, so we don't expect to get any significance for now. However, we would like to, especially in a meeting like today, that we can all find each other. We have the same interest. We can just do it, maybe scale it up to other parts of the United States so our sample size can increase. But we're going to follow the babies to see about their infant health in the well child visits until 1 year of age. And we're going to do an assessment by cardiology for the mother after pregnancy, 1 year after pregnancy. This goes along the lines of preventing and taking care of Chagas before the disease manifests itself. So the challenges, the ethics and the participant protections are very important, especially now. We are facing a few challenges in our questionnaires. We don't want undocumented immigrants to give us all their information, and what are we going to do with that? How are we going to protect them in case anything happens? So we have to be very careful with this. We have the certificate of confidentiality from NIH, but we have to be careful in every step so that we can protect our participants and not do more harm. So the unauthorized immigrant population, this is nationwide in the graphic. You can see it was increasing and now it seems to be stable, but this is immigrants from all over. In the state of Maryland, it's slightly increasing in the last years. However, if you see from Central America, it's steadily increasing. So we expect to see a lot of unauthorized immigrant in our study population, and as well as the civil unrest in El Salvador and Central America is not going to end maybe anytime soon, so we expect the immigration to keep flowing. Our future steps, as we would love to have more collaboration, since we already know we have the same goal, and to build momentum for more screening, targeted screening, but also countrywide. Maybe first in key sites, and then we could expand it to a nationwide thing. Treatment is also very important, especially in primary care. Children, women of reproductive age. And also look at congenital Chagas and the possibility of screening and treating babies while it's early. This is what I said before. Yeah, we also need a sample size that cannot be achieved in only one site, so it would be nice to collaborate. I want to thank Dr. Robert Gilman, Indira Chakravarti, and the whole team at Hopkins that has been very helpful. So thank you.